I'm Grace Hajinazarian. I'm a research assistant from Tufts University, and I'm here presenting on behalf of a large team some of our recent qualitative research work on providers' perspectives about prescription opioids. To give some background, pain, along with the need to treat pain, has been on the rise, and national estimates from 2002 till 2018 have shown that we have had a 10% relative increase in the prevalence of any reported pain among adults. So we can see that this is increasing, it's an increasing trend across all the age groups and across males and females alike. So naturally, we would expect that opioid prescription rates have increased as well, and that was the case for a while. However, there have been stricter regulations around opioid prescriptions, and we have seen a relative decrease in prescribing over these past few years. However, prescription rates, after the rate has gone down, have still remained substantially elevated in the US compared to international standards. And also, it has remained elevated compared to the rates that we have seen prior to the initial surge of prescribing that started in the late 1990s. A recent study has also found that there is a high percentage of patients who are prescribed opioids and who will continue using these opioids for at least a year after their initial prescription, and even up to 3 years after the initial prescription, indicating prolonged continued use of opioids. And various evidence-based practices and strategies which support providers to screen for risk of opioid use disorders prior to them prescribing opioids to patients are there. And these screening tools have been developed to assist providers in making informed decisions when they are prescribing these scheduled medications, and to also prevent the excess provision of prescription opioid medications to individuals with a substance use disorder or potential opioid use disorder. However, the effectiveness of these screening practices to detect opioid use disorder remains somehow mixed, and these screening practices greatly rely on the quality of communication between the providers and with the patients. So potential barriers in patient-provider and inter-provider communication may reduce the effectiveness of these screening practices at detecting opioid use disorder risk. This is why our research question looks at what are the current communication strategies which providers use when communicating with patients and with other providers before prescribing opioids and at follow-up visits as well. Also, what are the potential barriers in communication which providers encounter? And we mainly did the study because we believe that there's a need to understand healthcare providers' skills, comfort, and confidence when discussing opioids with patients and with other providers. And this is an important step in balancing patients' needs from a pain perspective, as well as mitigating the risks for opioid use disorder. And we use the health education theory for our qualitative work, and it has been used previously for provider-patient communication research that has been done. The health education theory posits a matrix, and this matrix is divided across patient and provider involvement, the degree of involvement of each patient and provider in the decision-making regarding the prescription of opioids. And there are four main types. It could be a mutual relationship, consumer, paternal, or default if neither is really involved, which is not really common. And we use this framework to develop our interview questions as well as to interpret our results through these different approaches. And we wanted to get responses that mainly fall in the mutuality zone, where there is participatory and shared decision making taking place between the patients and the providers, and neither side has a stronger influence in the decision making. Brief overview of the methods that we used to do our qualitative work. So we used purposeful and snowball sampling between January and September 2021. We interviewed 32 providers from a range of specialties. We had physicians, PAs, NPs, dentists. And before the interviews, we made sure to give everyone an eligibility screener to check that they had been practicing and prescribing opioids for at least 6 months and spoke and understood English. We also obtained informed consent from all participants. On average, the interviews lasted for 25 to 40 minutes on Zoom. Some example questions from our interview guide to elicit provider responses are to tell us more about conversations they had with patients, either initiated by the provider or by the patient, about concerns of prescribing more opioids than necessary, and what would they think prescribers in their field could be doing better to reduce the risk of addiction among patients. And we transcribed recordings verbatim, cross-checked, encoded, uh, analyzed the data. Some demographic and descriptive characteristics. Half of our sample was approximately female. Racial ethnic composition, A's and 5 NPs. We also had good diversity when it comes to age, also to the setting in which they practiced. Also, we asked about whether they used a screener before they prescribe opioids, and we had mixed responses on whether they did or not. And from our deductive content analysis, we derived main themes, 5 of which I will be presenting on. The communication style and content, communication with concerned patients and those who exhibit red flags, collaborating with other providers following up post-prescription, and some recommendations that the providers use or told us about that would reduce the risk in opioid prescribing. To touch on the first theme really briefly, it is a common theme that was really corroborated in the literature. We were looking at like an overview of the provider's tone, use of language, the content they covered, and we had very empathic responses generally. Like this emergency medicine PA here mentions, really just trying to have that sort of heart-to-heart conversation with them. And we see here that the element of mutuality that we had also been looking for from our framework. We derived a separate theme for communicating with concerned patients and those who exhibit red flags, because these are more challenging conversations. One emergency department physician mentions, I try to be cautious and generous. I don't want anyone going home in severe pain. I tell them, if we can get you to a 4 out of 10, that's fine. So they kind of manage their expectations. And a nurse practitioner also quotes, I ask, have you been addicted before to these meds? And if they say no, then I say, you just have a lot of pain now, and I can make a concoction. I can give you some gabapentin, some Tylenol. You need some opioids. You just had your chest open, and they understand, but I think there is a bit of education that needs to be done. And dentists also had a take on communicating with concerned patients. I say to them, listen, what you got going on is serious and it's real. I know I'm not starting you on a maintenance 5 times a day opioids. I'm talking about a one-time dose right now or something low dose that will work for a while and just take the edge off. And once that's worn off, we could discuss whether or not you need any more. And here we can see how across providers, some take a more mutual approach, others adopt a more paternal approach when they're approaching their patients about opioid prescriptions. As for collaborating with other providers, we had many mentions of collaborating with pain and substance use specialists in these cases, as well as with primary care providers. Um, the quote from an orthopedic surgeon mentions essentially, if there is a patient who at this point continues to exist on opioids, but I no longer feel comfortable prescribing, that would be a time when I might suggest that they see the pain management service. And the male orthopedic surgeon also quotes, anybody with a history of opioid use, I will loop in their main prescriber to kind of formulate a plan together. And this was also a particularly important theme when it came to following up post-prescription, and it came a lot in the interview. And many providers mentioned several ways that they would follow up with patients after they would prescribe an opioid. This was done through either checking if a prescription was filled by the patient, having them come back to the office, or calling another provider after a certain duration to check in on the patient. And we have a quote by primary care NP that mentions that we usually give them for the short period of time, less than 2 weeks, and especially for a week. After a week, I evaluate the pain and I reevaluate in a week and then extend the prescription if needed. Finally, we also came up with a theme on general recommendations to reduce risk in opioid prescribing because providers were mentioning also the strategies that they would employ in their practice and the strategies that would usually work for them to mitigate these conversations. And we had a lot of empathy, education, such minor themes come up. And one dentist mentions that the most challenging patients sometimes you have to pull in your mindset and be empathic with these patients, and sometimes we tend not to be that empathic with our patients and things like, hey, this patient needs me to get just needs me to gather narcotics, so I'm trying to have empathy with them, and that helps a lot. And a pediatric hematologist oncologist also quotes, in terms of screening, I think it would be helpful if we definitely had more education around depression and anxiety and substance use and stuff like that. That would definitely be helpful, but that's definitely not something we have in place where I practice. And before I discuss also our conclusions, it would be also important to mention that this was a qualitative study, so it was done during COVID-19, which might have impacted providers' perspectives on the whole opioid prescribing take during that time. And all providers are from Massachusetts, so our data, whatever responses we got, is not really generalizable to providers in other states, and it really takes a deep dive into how providers feel about this issue here. And lastly, the issue of subjectivity and interpreting qualitative data. All the protocols to minimize bias have been put in place, but at the end, it's inevitable how to interpret such data without a bit of subjectivity. So to conclude, open, supportive, tailored communication, this is reiterated from prior research, is essential when considering opioid prescriptions with patients. And we also came up with some directions that we would like to see in future research, where it is recommended to learn more about the current status of these prescriptions when it comes to providers' knowledge, beliefs, and practices. So we did come up with some next steps after we did all of these qualitative interviews, and we used them all to develop a survey. And just this summer in July 2023, we administered the survey to 328 providers in Massachusetts, and the survey covers a range of external and internal factors affecting their knowledge, attitudes, risk mitigation strategies, and prescribing practices. So currently we are working on developing a path analysis that looks at all of these factors. Thank you so much.